it's put on by all the town departments, trying to work together just to bring education to communities. This is our second of the series. We had the sheriff's department talk to the face-to-face program a month ago. So the series is going to continue to run. It'll always be the second Wednesday of the month. We have other speakers that are, we're trying to get. Other people have approached us already. It's also being filmed, so it's on cable. The face-to-face one is. This one will be, and we'll hopefully continue to do that. So thanks for coming out this evening. We have Tom Wilson from AIDS Project of Worcester.
Perfect. Yeah.
And he's our speaker tonight. So thank you.
All right. Good evening, everyone. I want to thank you all for coming out tonight. And I want to thank Nancy and Kelly for inviting me out to be part of this. As I said, my name is Tom Wilson. I work for AIDS Project Worcester. I also happen to be a resident of the town, so I'm very happy to be here to help the community and to see so many people come out who are interested in this crisis, because it's definitely a crisis right now. But now AIDS Project Worcester, if you haven't heard about us, we've been around for about 30 years, and we were started to address the AIDS crisis of the 80s, and then a few years ago we started adding services to address the opioid crisis that's happening now. And one of the services that we provide for communities and for people is training in NARCAN. And if you're not familiar with NARCAN, NARCAN is known as the overdose drug. And what it does is it stops opiate overdoses as they're occurring. But it only works for opiates. If someone is passed out drunk, it's not going to help them. If someone's agitated on other drugs, it's not going to help things like coke or crack or methamphetamine. This is going to help them. It's only opiates that's going to address. But the thing about it is, but if it ever to be given to somebody who's not using an opiate, it's not going to do anything. It's a benign drug. It's not toxic in any way. Like I said, if you give it to someone who wasn't using an opiate, it's not going to do anything. If you were to spray it on yourself, it won't do anything. Because one of the things as I go over the basics of this is that it needs to be kept at room temperature, and we always recommend you keep it in a place that you can get to easily, but that means anybody can get to it easy. So if you have children or grandchildren or family members, you don't have to worry if they were to get into it, play with it. Even children could spray this into their faces or mouths. It won't do anything. It's also something that we're saying is benign. People can't overdose on it. People ask, can you give somebody too much NARCAN? This is no. Now, there is the issue of talking to clinicians. After about 4 doses of this type of NARCAN, it's not going to do a person any much better. Normally, after 4 doses, their brain is saturated, and it's not going to help. But again, it's not going to hurt. And again, to go over some of the other basics of it, it's, like I said, it needs to be kept at room temperature, but it's also temperature sensitive. Above 80 degrees, it'll start to degrade, and below 50 degrees, it'll start to degrade. But it's sensitive to the point where what we mean is we don't want you to throw it into your glove compartment because it's easy to find, because obviously the car's going to cook in the summer and freeze in the winter, or throw it in the back seat in a bag so you can find it. It's something, but it is something that you could keep on your person. Like on a cold winter's day, it's 10 degrees out. If it's in your pocket, it's going to be fine. On a hot day that's in the 90s, if it's in a pocketbook's fine. We're just talking about prolonged exposure to these temperatures. But all it's going to do is degrade it. Again, it's not going to turn it bad. The other thing about NARCAN is it has expiration dates, but they're very long. Like these are good until September of 2019. So you want to keep an eye on the expirations. But since I was talking about the expirations and if they degrade and what happens to them if they're exposed to temperatures like that. But in an overdose situation, you always use the NARCAN you have. So if you pull it out and you see that it's expired, use it. Because like I said, it's not going to go bad. It's just not be as effective. Same thing if you know, okay, I have been leaving it in my car and it's cooked a few times. Always use what you have, because like I said, it's only degraded. It's not going to hurt anybody, and you might as well try to do something. Talk a little bit more about how NARCAN works. I just want to talk a little bit about how the overdoses actually work. And what happens is a person gets an opiate into their system. What it'll do is it goes up to the brain, it attaches to the brain receptors, and it gives them the euphoria, the high. But what it also does is it slows down the body functions, and specifically the lungs. So what happens if they get an opiate and they use too much of it, or if the opiate is too strong, then what happens is it slows the lungs down so much that then they're not supplying enough oxygen to the brain, then the brain shuts everything down, and that's how the overdose happens. Now what NARCAN does, and first of all, NARCAN is just a brand name. The drug is actually naloxone. But what NARCAN does is when it's administered to a person, and it's a nasal spray, and I'll go over that during the training, it goes up to the brain, goes to the same brain receptors, and what it does is it wipes the opiates off the brain receptors, and then it attaches to those same brain receptors, and it blocks the opiates from reattaching. Now, the important part of this is that it blocks the opiates from reattaching. It doesn't eliminate the opiates. It doesn't get it out of a person's bloodstream. It's still in the person's bloodstream. And that's something too important to remember, and I'll discuss that a little bit further as the training goes along. But it'll immediately stop, it stops the effects of the opiate and allows the body to start functioning again. But as far as the to recognize an actual overdose, in an overdose situation, when I'm doing street outreach, what I look for is people who we call them unresponsive. And when I'm talking about that, I'm literally talking about someone who may be passed out, or they're so high that they can't respond to me. If you've ever heard of the term like people nodding off, they are actually nodding. They may be sitting down and nodding. It's like they're going in and out of sleep. So for my purpose, if I find someone who's passed out, and especially in the city, if you see somebody at a bench or someone's passed out, what I would do is basically just go up to them from a distance and maybe touch them on the shoulder, say, "Hi, how you doing?" Just to get them to wake up, because one, they just may be homeless and sleeping, and I just want to see how they're doing, and sometimes they'll come up and they're fine, but otherwise, sometimes they may come up, and I can tell from looking at them that they've been using, and what I look for is like their eyes, the pupils will be very pinpointed if they've been using opiates. And then, if I woke them up from being high, they will maybe start the nod effect. So I can tell that, okay, this person's been using, but I don't know yet, are they high or are they overdosing? So then what you could do is just talk to the person, say, are you sure you're okay? Can I call somebody? Do you want me to get you some water? What I'm trying to do is get a rise out of the person, to have them say, dude, I'm fine. Or the other thing you can do, and what I've done before with people, is say, do you need to be Narcaned? Because if a person is actively using, they know what Narcan is. And what Narcan, one of the side effects of Narcan is it'll cause the person to go into withdrawal. When they come to, they're going to be going through withdrawal. They don't want to be going through withdrawal. So if you were to say to a person, do you need to be Narcaned, and they hear that, they're going to be, no. They'll wake up fast and say no. So that lets me at least feel at that moment, okay, they seem to be okay. They don't need to be Narcaned. But for just general knowledge about this, overdoses don't happen immediately either. Sometimes they take 5, 10, 15 minutes. So for my purposes, I would circle back to that person later on, just to see are they still there and how they're doing. And for your purposes, if you see somebody outside who seems to be in that position, you may want to, if you're out running errands or something like that, when you come back, you may want to go back to the same area to see. Or if it's somebody, if you're out to dinner someplace, or just stopping in at McDonald's or one of those types of places, a fast food place, and you see somebody who looks like they may not be quite right, you may want to just keep an eye on them to see if they eventually just put their head down and they go out. Let's say for the sake of argument, the person doesn't come to. What I'll do first, if a person doesn't come to, what I'll do is call 911. I'll let them know that I think I have an overdose situation here. And after I do that, the next thing you want to try to do is wake the person up. And to try to wake the person up, what we suggest is you do a sternum rub. And what you do is you take these two knuckles, and you go to the person's sternum, you know, the bone at the top of the chest, below the throat, and you rub it real hard. And you can rub it quite hard because it hurts. And that may wake the person up. If you can't get to their sternum, you can go above their teeth and below the nose, and you can rub back and forth. And again, don't be afraid to rub it good and hard because you're trying to wake them up. And the idea behind waking them up is, like I had mentioned, that the problem during the overdose is they're not getting any oxygen because their lungs aren't functioning. By waking them up, sometimes people go, and they take a gulp of air. Because besides trying to save their life, we're also worried about the quality of life. And after 4 or 5 minutes, if they don't have any oxygen, the potentially there's brain damage going to set in. So we like to try to take a moment to wake them up because we know that'll give them and us more time to revive them. But let's say they don't come to, or even if they come to, even if the person comes to, in all likelihood, they're not going to stay awake. We did that basically to get them to take the gulp of air, and you'll see their eyes like roll right back in and they'll go off again. So what you do is if the person doesn't wake up, or even if they do but they go back down, what you do next is you'd lay the person down if you can. And when you lay them down, we also recommend that you straighten out their airway. And you just do that when you lay them down, you lift up their head by their chin, and then pop open their mouth and make sure there's nothing in their mouth that they could choke on. And then you'd use the NARCAN. Then this is the NARCAN. If you want to, I'll get some others, just pass around. You can take a look at them. Ask that you not open the package, but you can check them out. And what you do with the NARCAN, it's very easy. It's a nasal spray. All you do is peel off the back. There's nothing to assemble. There's no cap on this. This is all the mechanism. And all you do is you put your fingers on both sides of it. This piece right here in the middle is the trigger or the pump. You'd stick that up the person's nose until their nostrils against the back of your fingers. And you press on that pump, and you're going to feel and hear like a little bit of a pop, because this has a little bit of pressure in it. And that'll disperse it into the person's nose. Because it doesn't go into their lungs, it's going up into their nasal cavity, and that's how it gets absorbed into the brain. And you would do that. Once you do that, then we recommend that you start some rescue breathing. If you know CPR and you're certified in CPR, by all means do CPR, but if you don't, we recommend rescue breathing. And that's simply you pinch a person's nose, you put your mouth over their mouth, you give them 2 quick puffs of air, and then you give them a puff of air every 5 or 10 seconds. Now, if you're worried about putting your mouth in somebody else's mouth, the NARCAN normally comes in a bag. If you still have the bag, you can always punch a hole in the middle of the bag, put that over their mouth, and use that as a barrier. You could go to Rutland Pharmacy or any pharmacy, ask them if they have CPR barriers, and basically it's going to be a piece of plastic like this that has a mouthpiece on it, and you can use that as a barrier. Normally they fold up so small that you can actually attach them to your keychain, so keep them in your pocket, and you can use that as a barrier. Also, cotton material is a good barrier, so if you have a t-shirt, if they have a t-shirt on, you could put that up over their mouth and use that as a barrier to do the breathing. But the fact of the matter is they need the oxygen. So we try to stress that to people, is that the breathing is very necessary. So by all means, use a barrier. Then you do that rescue breathing for about a minute. If the person hasn't come to, then you'd use the other NARCAN. The NARCANs, they come to a package. And you'd use the second one the same way, but try to remember to put it up the other nostril. If you put it up the same one, it's okay, but it works better if you put it up the other nostril. And again, give them the full blast. And go back to doing the rescue breathing. And you'd continue doing the rescue breathing now until the EMTs or the police show up. Now, if you have other NARCAN, you would use that like in another minute. But let's say if there's people around, you could always ask them too, does anybody else have NARCAN? Because one of the things I didn't mention about APW is we are the distributor of NARCAN in central Massachusetts. We do a lot of trainings out in the communities. I work in Gardner, Leominster, Fitchburg. I've been up to Winchendon, Westminster. I'm going up to Petersham soon. And so there's a lot of NARCAN out there. And then in the city of Worcester, we, one of our services is syringe services, which is the needle exchange. And all of our clients who come in for needle exchange, I would say more than 80% of them carry NARCAN on them. I bring it up again, if you're in an overdose situation, now you've used up your NARCAN, you can ask the people around, does anybody else have NARCAN? Because some of them, if they're friends of the person, they may have NARCAN on them. The other thing you could do is if the person has a backpack or it's a young lady with a pocketbook, what you can do is empty it out. Because if they're an active user, in all likelihood, they'll be carrying the NARCAN. Because like I said, a good 80% or more of our people carry NARCAN because they know it stops overdoses. So you can empty out backpacks or pocketbooks to see if they have anything. But I warn you, don't reach into them because there may be needles. And you don't want to be pricked by an exposed needle. Same thing going in people's pockets. I mean, you could pat their pockets to see if they're carrying anything, but pockets are a little bit more dangerous putting your hands into their pockets because there's just no room and you could get pricked by a needle. But those are the other ways you can try to find the NARCAN. But let's say the person comes to. When the person comes to, they're normally very confused. They're going to be going through withdrawal. A lot of times people don't think they've overdosed. And the thing is, at that time, you want to give some people some space. Because like I said, they're very confused. They don't think they've overdosed. As far as even though you've just saved their life, a lot of times in their mind, what you've done is you've screwed up their high. You've wasted the money that they've spent maybe half the day hustling, trying to get the drugs. And so even though they should be happy, most of the time they're not. So you just want to give them the distance just in case they lash out at people. But what you can do, we recommend is, but talk to the people to say, geez, are you okay? Do you need anything else? The idea behind talking to them is we want to slow them down so that they don't leave before the EMTs and the ambulance get there. Because the reason being is that I was saying before how the drug is still in the system, the opiates are still in the person's system. Well, the thing is that NARCAN has a limited life within the body. So if a person's using straight heroin, after about an hour and a half, they could go back into the overdose. Actually, it's more like an hour and a half to 2 hours for heroin. They could go back into the overdose. If the heroin they have has fentanyl in it, or if they're using just straight fentanyl, they could go back into the overdose as quickly as a half hour, 45 minutes. So we don't want people getting up and walking away before the ambulance and police can get there and they can convince the person to go to the hospital, because we want to eliminate the chances of them going back into the overdose. The other reality in drug use is that I mentioned that when the person comes to from the overdose, they're going to be going through withdrawal. No user wants to be going through withdrawal. Excuse me. And the only way to get rid of withdrawal when you're using is to use more. Well, they've been NARCAN'd, so if they try to use more, it's going to be blocked because the NARCAN is still on their brain, and it's going to block it. So, but what's happened now is they've added more opiates into their bloodstream, and it's still floating around in their system. So if they use, and then sometimes they'll use more to try to break through. They think they can break through the NARCAN. Well, that's not going to happen. So now they flood their system with opiates, and if they've taken off to do that, in all likelihood that next overdose is going to be more deadly because they have more opiates in their system. And in all likelihood there won't be any NARCAN around this time. So we always want to slow people down to make sure we give the chance for the EMTs and the police to show up to take control of the situation. One thing I forgot to mention too is that when I was talking about laying the person down who's unconscious, sometimes you may be in a situation where you don't have the NARCAN on you. You have to go to your car, you got to go someplace to find it. Never leave a person on their back who's unconscious, because conceivably they could vomit and they'll choke on their vomit. So you want to leave them, you want to put them on their side. You recommend that you roll people on their left-hand side, and when you roll them over on their left-hand side, make sure you drape their right arm and right leg over them. That way if they wiggle around while you're gone, they'll end up on their stomach in all likelihood and not in their back, so we don't have to worry about them excuse me, asphyxiating on their own vomit. One other thing people sometimes ask about the liability of doing this. Well, in Massachusetts, we do have the Good Samaritan law. So if you do accidentally injure somebody when you're administering NARCAN, whether you split their lip when you're doing a nasal rub, a sternum rub on their lip, or if you try to lay them down, you drop them, they break their elbow, they can't sue you. That's the idea behind the Good Samaritan law. And the other good thing that the state has done is they've expanded the Good Samaritan law too, where active users are now encouraged to call 911, because what the Good Samaritan law does now is that if you were in my apartment and we were using and somebody overdosed, and I call the police and they come, they don't search me or they don't search my apartment because I called and I'm the one who administered the NARCAN. Because before, people, they're worried more about getting arrested than they're worried about saving the person's life. So the state expanded the Good Samaritan law to allow the police and the EMTs to go in and have the users not worry about being arrested at that time, which we think is a good thing, because like we said, you've heard stories of people just getting dropped off at emergency rooms, people just being abandoned on sidewalks, and we just don't want that happening, because that's how people die. The other thing I just wanted, I've been talking about opiates, but I just want to make sure everybody understands what opiates are. We all recognize the term, heroin. It's been around a long time. But I've mentioned fentanyl, and it's been in the news more. Fentanyl is a man-made opiate, but it's extremely dangerous because it's about 50 to 100 times stronger than regular heroin. And that's what's really driving all the overdoses now, because this is relatively new in the last year or two that fentanyl has been showing up in the streets. And because it's so strong, people who are actively using before, they don't have the tolerance for it anymore. And because it's so strong in such tiny doses that the drug dealers who cut this stuff into heroin or cut it into other products, it's very easy for them to make batches that are very deadly, and that's why people are overdosing so much. And the other thing with the opiates is, and don't forget about the opiates that some of us may have in our medicine cabinets right now. The Vicodin, Percocet, OxyContin, oxycodone. These are all opiates. And I found in some trainings that I've done, people have asked me that if Vicodin or something like that was an opiate. And it occurred to me that a lot of people don't know what opiates are. And I know from my own personal experience that from sometimes being with doctors who've prescribed opiates, there's not a lot of discussion that you're getting a very dangerous opiate. And it's something that the medical field is addressing, but it's just something that just never happened because they never used to worry about it that much. We didn't have this crisis that we have now. So that we want people to be aware that some of the drugs you have in your medicine cabinet are opiates, and they're still very dangerous because you don't just overdose because you've injected something into your veins. You can overdose by taking the pills, you can overdose by smoking it, you can overdose by snorting it. It's not just injection drug use, it's any type of drug use. And with your medicine cabinets, I always recommend that and honestly, they're prescribed to people for legitimate and good reason. I'm not saying that they shouldn't be prescribed and we shouldn't take them, but when the prescription is done and you don't need it anymore, it shouldn't be kicking around in your medicine cabinet because you don't know who goes through your medicine cabinet. Not to throw the tradesmen under the bus, but I've talked to plenty of tradesmen who have substance abuse issues where that's one of the places, whenever they're in somebody's house, can I use your bathroom? Sure, and the first thing they do is they go to medicine cabinets. You may have family members that we don't know who may have substance abuse issues who are looking in your medicine cabinets. So whenever they're done, my point is to understand the police department has a drop-off. You should drop it off. You shouldn't keep opiates in your house if you don't need them because they're just too dangerous to have kicking around the house. And a lot of people are aware that they may be in people's homes, and it's easy access for them. Does anybody have any questions about what I've gone over so far?
I have a couple questions.
Sure.
And to bring it down, this is on television, right?
Yeah.
To bring it down to layman's terms, okay, average citizen in Rutland.
Yeah.
We're 20 miles out of Worcester, or
Yeah.
15 to 20 miles out. You're walking down, for instance, the State Park area, hiking.
Mm-hmm.
We don't carry fentanyl with us as the average person in town. We might have
Oh,
a cell
not
phone
here.
nowadays, so I think, and police departments here, what's the response time to someone, say, on the edge of the state park down off 122? You've got the NARCAN, I believe.
We do have
What would be your typical response time? So 911 cell call goes to state police first. I don't know what the turnaround time is to actually get a cruiser on site.
Minutes.
Minutes.
Yeah. Because the state police are cut out of the equation. Rutland Regional Dispatch is now taking direct 911 cell phone calls. So that cuts out a little bit of time out of cell phone 911 calls. So yeah, from center of town to down any of the state park entrances is probably about 5 minutes or less.
And we've got more than one cruiser on the road most of the time, correct?
All the time.
Okay. I just want to bring it down to layman, the average person in Rutland, we're in a hiking community, really, when the weather changes a little bit. And now when it get a little bit warmer, and we've got the hiking trails, the state park, the big forest. And just want people to be able to understand that we're going to get help if we make the call.
Oh, yeah. And hopefully you may have the NARCAN on yourself.
Yeah, well,
Because it's a small package. I very rarely go any place without it because you just never know when you may stumble across something.
Can the average person just go get that?
I'm glad you asked the question. It's something I didn't go over. Normally, you need a prescription in Massachusetts to get NARCAN, but the state of Massachusetts has an agreement with CVS, Walgreens, and Rite Aid that if you go in and request NARCAN and you're a Massachusetts citizen, you should be able to get 2 packages of NARCAN. You would have to pay, it's not free, you'd have to pay the copay of your insurance. But I know, like for Mass Health, some of the copays are as little as $0, or sometimes they're as high as $2, $3, $4, $5. I'm not sure about some of the private insurances. But without insurance, they cost, I've heard anywhere between $120 to $150 for a package of 2.
So now, this is something, 2 things that me as an average person did not know, that you could do that, and also that that doesn't go to the state police. People
That's
don't know
very
that.
recent.
I'm sorry?
That is very recent. I think I read
Okay.
about that. It is now.
Yeah, that should be out there.
Yeah.
And also, like I said, in AIDS Project Worcester, in Worcester, also distributes it for free. Anybody can walk in and say, I'd like to get some NARCAN or get trained on NARCAN, and we do that quite a bit. A lot of business owners will come in who have businesses in downtown Worcester. They know that it's an issue in the town, so a lot of them will have it.
Because I think
This-
that would be good for us to be able to get that in case we need to help someone.
Yeah, because you never know. I mean, it could be simple as, and I'm not even talking about substance abuse issues all the time. It could just be simple, an accidental overdose. That's why we like to discuss the meds that are in homes, because it's very simple for someone to mix up their meds or for a child to get into it. And the NARCAN is effective on a child, and it won't hurt a child. And I'm sure some of us have seen some of the news stories about even infants who have overdosed because their parents use, and they've had the narcotics on their hands, and they've touched the infants, and now the infants have absorbed it through their skin, and they've overdosed, and they've been successfully revived by using NARCAN. So that's the thing. There's a lot of potential for accidental overdoses with the amount of prescribed drugs out there.
And I think one of the things people don't seem to realize, we're in a town, 2 towns out, so we're a bedroom town. And the drug problem is in Worcester. Well, guess what?
Oh, no,
It's not in Worcester.
It's here.
It's here.
It's pretty prevalent here in a
absolutely
little
here.
town like this, and it's under the rug. It's just
Yeah.
not.
Well, that's why, besides doing the NARCAN training, I like to discuss these things so we can also just eliminate some of the stigma. And you brought it up. It's not just an inner city thing. It doesn't just happen in Worcester. It doesn't just happen in Fitchburg. It happens all over now. Because there's just so much of it out there. And the other reality is, even for someone like my age, and I was no saint when I was a younger man, but there was not opiates available out there in the amount that are out there now. There's tons of opiates out there. And it starts with, even when you think about how much gets prescribed, and I'm not pushing the medical industry under the bus, but they didn't have the amount of opiates to prescribe back then. And then at a point in time in the 90s where the medical industry was very worried about the amount of pain people was in, and at that same time a drug like oxycodone was developed, which was also then marketed as a less addictive opiate, which wasn't true, but nobody found out about that until years after it was being prescribed, and the doctors weren't aware of it either. So now the horse is out of the barn. And that's one of the drivers of the epidemic we're in now is the amount of prescribed drugs out there. But we also have a responsibility to ask questions now when we're getting prescribed things to make sure we know what we're getting. And again, that's it's part of the issue. That is not the sole issue of our drug epidemic, but it's just part of the things that we can help by just asking the questions. Does anybody have any other questions?
Can you comment on the availability of the NARCAN? Do you think that makes the abuse worse because the users know that there's something that could save them?
It's a good question. A lot of people brought it up, but I'd say no, because it was in response to the fact that it's a drug that can save someone's life, but they know that yes, it does save lives, but there may be situations where NARCAN is not available, and because they're in the middle of a substance abuse illness, they're not going to not use if they don't have NARCAN. So if they don't have NARCAN, they're still going to use. And a lot of the people that I talk to on a daily basis, no one's ever mentioned to me that, oh, I'm so glad I have NARCAN, so now I don't have to worry about dying. No, they're very much worried about overdosing, and that's why they carry it. But I'm glad, I'm very glad you asked the question. Because it leads to another question that no one's asked, but I'll bring it up, is, and why do we even bother doing this if this is something that people do, this is something that they're inflicting upon themselves? Well, I just want to bring up the fact that there's a lot of medical issues that are deadly to us that we bring upon ourselves right now. If anybody who's ever smoked before, that is a conscious decision, and it says right on the packet it's going to kill you. But we would not deny a cancer patient who's smoked for 30 years cancer treatment, even though they chose to smoke and it tells you not to smoke. I'll use myself as an example. About a year and a half ago, I had a heart attack. Now, obviously, I'm overweight. I've lost weight, believe it or not, but I need to lose more. But what if the doctor said, well, listen, Tom, these are your meds. I'll give them to you for a year, but if you don't lose another 50 pounds, no more meds. Well, I would like to think they wouldn't do that to me because I had an illness, even though it's my choice of, are you going to cut back on the fried foods? Are you going to exercise more? Well, there's a lot of us out there who don't do what we're supposed to do, which causes us harm, and we all pay for it. So I don't want it to be an issue of this fight of who does and doesn't deserve medical care, who does and doesn't concern our empathy when they're sick, because opiate addictions, it's an illness. Yes, you do have to start, but some people start and they don't even realize they've started, again, for the issue of medications that are prescribed to people. They don't realize what they're getting themselves into. And then they don't know how to get out of it because we don't talk about the issue enough. And there's a stigma about nobody wants to admit that they're addicted now to painkillers. And these painkillers, the meds, can be bought on the street, but now you're talking about $60 to $80 a pill, while the same people who are selling those pills to people, well, they also at some point, when I can't pay $60 to $80 for the pill, they're going to say, well, you could buy this for $20. Oh, but I'm not going to shoot up heroin. No, what you can do is you can snort it. Oh, so now all of a sudden you're snorting heroin. Then it's like, well, it would be better if you shot it up. Well, I can't shoot up. Well, here, you look the other way, I'll shoot you up for you. And then that's it. And that's what we hear those stories a lot. That's how people get caught up into it. And they don't realize what they're getting themselves into. Because it does have an effect on the brain, where now the brain is more consumed with getting the narcotic than anything else in their lives. And what's also very difficult about this is that it's a very difficult sickness to get over. Many people go into detox, but it takes, on the average, probably more than 6 trips to detox before some people can get themselves clean. And I know some people have been to detox 10 or 15 times. I mean, it may seem discouraging, but the more I hear people going into detox, I feel better that, okay, but sooner or later now it's going to click, because they've been in there long enough, and they're learning the different things they need to learn to try to stop this. But one of the other factors in this for people who are stuck in addiction is normally when they get to the point of the addiction really taking over their lives, they've also burnt all their bridges. They don't have a family to back them up anymore. They don't have true friends who are going to back them up anymore. And if there's any type of mental health issue involved, and sometimes by this stage of the game, they may also be dealing with homelessness. This is a sickness that you need a lot of support. And if you're homeless with no family and no friends, this is a very difficult thing to defeat on your own. And that's why people have to go through detox so much, because they don't have a lot of supports. And that's why I'll just talk a minute about what we do with needle exchange, because a lot of people, if people don't like the idea of there being NARCAN out there, you can be sure as heck they don't like us giving needles to people. But we're not just giving needles to people, because that's what people think, oh, you're just giving needles. No, what we do is we're practicing what's called harm reduction. We know they're doing something that's harmful, but let's try to reduce the amount of harm they're doing. And clean needles, first of all, it reduces the amount of HIV that's out in our communities. It also reduces the amount of hepatitis C. We see all the commercials about hepatitis C nowadays. And one of the big drivers is intravenous drug use, or injection drug use, because it's blood-to-blood contact, so you get a lot of hepatitis C. Well, by us providing by us providing clean needles, then the amount of hepatitis C in the community goes down, so then other people may not contract it. Same thing with HIV. You have less people walking around with it, so then obviously you have less people contracting it. But the other thing is we don't just give out needles. It's not like McDonald's where you just come in, get your order, and get out. The people have to sit down with us, and we talk to them. And, you know, like I said, our organization probably sees about, I'd say around 500 or 600 people a month come in to get clean needles. We probably have about 1,500 people enrolled in the program. And by seeing the people so often, we form relationships with them. I get to know the people. And then once I get to know the people, I can start talking to them about their lives, about what they used to do, talk to them about their current health. A lot of times when I'm talking to people and they're describing different things that are happening in their life that's related to the illness of substance abuse, I bring that up to say, wow, that's it's a consequence of the addiction. That really stinks. But I always say the consequence of the addiction, it's not you, it's the addiction that's now taken over your life. And then I use that to say, and that's why I want to get you healthy. And I'm not the only one. There's a staff of like 5 or 6 of us who do it. You know, it's so we try to build relationships with people so we can steer them into treatment, or at least give them hope that, yeah, there is a chance for treatment. Like, for instance, I'll use an example of some young men I know from talking to them. They've been honorably discharged. And, you know, I've spoken to them about the fact that, you know, if you were to get yourself clean, what a compelling story. I said, you know, who wouldn't want to help a veteran out nowadays? And I said, you'd have a compelling story. And I've had guys thinking, well, yeah, that's true. I said, yeah, and some of them have had, you know, they do have job skills. Then I said, well, if you can get yourself clean, you know, think about it. And then you can get more involved with the VA, and they're very active in helping people. So it's like information like that. Find out about people who obviously, you know, don't have contact with their children anymore. You know, so I may talk to them like, well, if you were getting clean, do you think you'd get supervised visits? Well, yeah, I never thought of it. You know, we just plant seeds inside people as we're talking to them about, if you can get away from this, think about what will happen over here. I mean, it's not that easy. It takes a lot of time to do it. But just to guilt people into going into detox, or like basically forcing them going into detox, it's not a good situation because it won't work. If they don't want to get healthy, they're not going to get healthy. And that's another driver of, excuse me, of overdoses too. When people go into detox, the detoxes are sometimes 3 to 5 days. When they come out, in just a matter of 3 or 5 days, their tolerances have gone down. So when they come out, they're very susceptible to overdoses. And that's another thing we do during our harm reduction or needle exchange, is we're talking to people. Whenever I hear somebody say, yeah, I just got out of detox, well, that changes the conversation, because now I have to remind them. I said, well, you know your tolerances are down, right? You're not going to go using the same amount, right? Do you have NARCAN on you? It changes the conversation, and I create a little bit more serious about the conversation, because you do realize this is dangerous. So that's what we try to do with people, is to make them aware of what's going on, what they can do to reduce their risk, and then try to steer them into treatment. Because this is not something that, for a lot of the people, this is not something that they're really getting much joy out of anyway. Because once they've been using actively for a long time, they're not getting high, they're not getting much of a euphoria anymore, they're just not getting sick anymore. And they just have to use it to function now. But there is no high about this. And it's a very difficult life. And what'll help is if we have a little bit more empathy, and so that people can talk about it more, and we can try to, the more people talking about treatment and trying to help people, they'll realize that they can come out of the shadows and try to get to treatment. Does anybody have any other? Sure.
Just to touch upon what you said about people who may lose contact with their children, because this is a huge problem now.
Yep.
So you have these little kids that are affected by this. How is the state recognize? I mean, I know they recognize it, but where do you draw the line where you put more effort into having these children have better lives versus do they keep it open longer so that in case the person gets better? When you talk about visitation, or do they take?
Yeah, I really can't speak with any authority on how they deal with it. I do know that children are normally removed relatively quickly because of the dangerousness of the situation. It's unfortunate a lot of women who are pregnant sometimes are also active users. Most of the cases in those situations like that, when the children are born addicted, they normally go right into DCF custody unless there's a family member. You know, you hear about a lot of sisters, brothers, grandparents who take children in now, and a lot of that happens, which is, you know, just personally I feel is better that the child stays within the family. But you know, they watch for the safety of the children pretty fast in those situations. And unfortunate, even that's how strong the addiction is too. Unfortunate that you would think that if someone had children, they could change their behavior quicker when it cost it, but no, it doesn't happen that way because the addiction is so strong. Yeah. Yes, sir.
John, can you touch on like what kind of services you can provide as an outreach worker to people in town? How you
Oh,
help
sure.
a family going through?
Yeah, sure. Well, I've got my card and some literature about my organization over there. I had mentioned to the chief before that, you know, if people wanted to reach out to me, they could reach out to me at my agency, and I can make arrangements to meet with people or meet with families here in town, just to go over any questions they may have, or if they have any, yeah, basically any questions that they may have about family members or friends who are dealing with it. Because since I do live here in town, I might as well be a resource to the community. Because like I said, you know, I deal with hundreds of people who are dealing with this crisis. And I talk with a lot of families. Families will come in and they're getting NARCAN trained because their children are active users and they don't know what to do, but they know they should at least do this because they've been told, well, get NARCAN in the house. So I can talk to them about what you need to be looking out for. You know, and then actually, and that's a good thing, you know, and one of the things that people should be looking out for with children and stuff, when all of a sudden they're always wearing long sleeve shirts. They're always wearing their collars up because people shoot up in their arms, and then when your veins are gone in your arms, you go into your neck. So you may notice that people are that type of behavior. You know, the pupils being pinpointed. There are things like that that parents can look out for. You know, and again, it goes back to and look out for your prescription drugs to avoid that. And also, a lot of times when these things happen, as much as there's a lot of treatment and opportunities out there for treatment, unless you're in the middle of a situation, you don't know that, and that's something I can also help people with. If they need to find access to treatment centers, I can do that. And treatment centers, say, specifically for women or specifically for men, residential treatment. There's a lot of residential treatment available in the state of Massachusetts. Because a lot of people talk about, you know, there's not enough beds, there's not enough treatment. There is quite a bit out there, but it's just a matter of getting people to go and having them go under the right circumstances. And when I say the right circumstances, we have a limited amount of control on that, but it's basically when they're ready to go. But all you can do, you only know when they're ready is by listening to them and talking to them a lot, and then slowly steering them in that direction when you can see that, okay, I think this is the time to do it. But like I tell people, you can have lots of hope, just don't have your expectations too high because it's such a difficult illness to kick. So just to get someone to go into treatment that first time, that's a huge victory, I tell families, just to get them in there that first time. Just don't be too upset if they can't make it the first time, and just shoot for the next time. But always have NARCAN in your house or around. And where the chief mentioned about service I can provide for the town. The other thing, just talk about services that APW provides. We also provide free testing. I mentioned like HIV, Hep C. We also test for sexually transmitted diseases, and that's all free and anonymous. So if you know of any family members or friends who are, you know, they need to get tested, but they don't want to see their primary care physician, well, that's one of the things that we can do. They can come down, and it's anonymous and free, and they can get tested.
And I think you gave your location.
Oh, I'm sorry.
Hearing.
Sure. It's at 85 Green Street. And if you take some of the, I'm sorry, Green Street.
Oh, Green Street.
Green Street, yeah. Down just beyond the Worcester Library, if you're familiar with Worcester, underneath the Green Street Bridge. Yeah, yeah. So people can come down there. And again, people can come down there, whether they talk with me or they can talk to any of the we're called outreach educators. Talk to any of the outreach educators about any issue they may have. And it's not just opiates. We'll talk with people. We have access to treatment for a lot of the drugs too, as far as things like cocaine or crack, because they're still prevalent out there. It's just that they're not killing people at the pace that this is. Yes, sir.
I think the program is a Matri. Do you know that? It's an opiate blocker they're using now. It blocks
That one-
opiates and alcohol.
Are you talking about Vivitrol?
Vivitrol, yes.
Vivitrol,
yes,
yeah.
yes. Has there been any success with that?
Yeah, Vivitrol is a more recent drug. Well, I wouldn't say it's more recently being used for people who are dealing with opiate addiction. It used to be used just for alcoholics. And what it was is that you have to have alcohol or opiates out of your system, I think, for 2 to 3 weeks before you can be given this injection. Because if you have alcohol or opiates in your system and you're given this injection, it makes you very sick. But then what happens after the fact is once you have Vivitrol in your system, bless you, once you have Vivitrol in your system, if you try to drink or you try to use opiates, it's going to make you feel sick. And you also won't get the effect of them either. And it's not something that you can break through. And the shot lasts about a month. The good thing about it is that people don't have to take it, like if they're in Suboxone, that's a pill generally. They don't have to take a pill every day. They don't have to remember to take a pill. And also, you can't skip your pill. Once you've been given your Vivitrol shot, you've got your Vivitrol shot and you're stuck with it for 30 days until it wears off. The thing with Suboxone is you could just stop taking your Suboxone for a few days and use opiates and then go back on your Suboxone. And methadone is the same way. It requires you to be going to the clinic all the time to get it, and some people can't do that regimen to do it. So that's more of a more recent one. It's very what I like about it too. It's very prevalent in the jail system now, because a lot of people, if they want, they can get a Vivitrol shot before they leave. If they get into a treatment program, they'll get shot with Vivitrol before they leave the jails, also to help try to keep them clean. Did you have a question, sir?
Yeah, can you say the name of the drug, because I can't hear?
Oh, I'm sorry, Vivitrol.
Vivitrol?
Yeah, Vivitrol.
I got a problem with my brother-in-law, and
Yeah. And normally, I think what they'll do,
they were talking about doing that.
yeah. Normally, people need to go through detox. For any of these things, they normally need to go through detox first.
He
And then-
detoxes about every other week. Goes into
Okay.
the hospital.
Mm-hmm.
And he went in 30 times last year.
Yeah.
And he's in twice this year.
Yeah.
He's in a coma.
I'm sorry to hear that.
At this time, but not time
Yeah,
before.
I'm sorry to hear that. But the more he goes into treatment,
You know, he's an in-law, so I can't do anything about it.
yeah.
I tried to help him, but I can't do anything about it.
Yeah, well, yeah, all we can do is try to help people, but I just remind people that we didn't cause the problem and we can't cure the problem. But we can help people, but we don't have too much on the end result. It's still up to the individual to make some of these, to make these decisions. Because,
He's he was supposed to start that shot this week, but he's back in hospital again, so.
yeah, and that's the thing with those shots. You can't stop them. You can't stop them if you don't have alcohol
Yeah,
or the opiates out of your system.
I didn't realize it, but he had started drinking, so.
Yeah.
That's what we're here for.
Yes, Nancy.
How do parents tell if there's a problem? I know you said the pupils might be different, but nobody is none of these kids are gonna admit it. In fact, right, they're gonna fight you on it.
Mm-hmm.
How do you really tell? Like, I mean, if somebody's an alcoholic, at least from my experience, from anybody I've talked to, a lot of times you can tell, even if they're a functioning alcoholic.
Mm-hmm.
But like you had mentioned, at some point, they don't get a high anymore, they just need it to survive, bless you. So what kind of time are you talking about?
Oh, I'm talking years. I'm talking years as far as people not having the effect. It'll still affect them, but it's just not the same high. It's more of a that nodding off state. So you're not going to use it in just walking around functioning very well. So even for people who have a high tolerance, they're still going to have a hard time functioning. So with children, or younger adults, not so much children, but younger adults and children, well, they wouldn't be able to hide it on you, especially in opiate abuse. They wouldn't be able to hide it because they would be dozing off. There would definitely be school problems. It's slowly but surely, it takes control of people's lives. And the other issue nowadays is, again, I talked about heroin, but I was also talking about fentanyl, and I don't know if I'm repeating myself, but about 90% of what's out there is fentanyl. Well, the thing with fentanyl is fentanyl gets out of a person's system very fast. So for an average user who is using heroin, you could use, and you wouldn't start going through withdrawal maybe for about 6 hours or so. In going through withdrawal, you stop by maybe, it's almost like you're starting to get a cold. You're getting a stuffy nose, your body's starting to ache. Well, then that progressively gets worse. But like I said, you can go about 6 hours with that. So some people in the past have been able to be heroin users and be functional, because if I get up in the morning and I used a little bit of heroin, I could go to work my 8-hour job. Maybe about 6 or 7 hours in, I'm not feeling so good, but I can work, and then by the time I get out of work, I can use again, and then I'm not sick anymore. Fentanyl will be out of a person's system. They'll start feeling withdrawal in about 3 hours. So the problem with fentanyl being out there is that now what's happening is it causes people to, if they were functioning, they're now losing their jobs because they have to use at work. They're getting very sick at work, which causes people to lose their jobs. Now you're also talking about sleep deprivation, because the withdrawal doesn't go away just because you're asleep. So if you use before you go to bed, say at 10 o'clock, well, guarantee you at 1 or 2 o'clock in the morning, you're going to be waking up sick. You have to use again.
But what do people at your job do? They don't know that you're, that if you used at 7 o'clock, you're at work at 8, and you say you last most of the day, nobody can tell?
Oh, no. They'll, well,
what would you look for? Or how would
if they were using heroin and they were kind of going through the day? Well, no, they could probably like function a little bit. They may not be as attentive, but depending on your job, you may be able to pull it off. For some of I can imagine some jobs you'd be able to pull it off because you're not really that high. They're just using enough so as they're not going to be sick anymore.
So that's after you're talking like years of use?
Yeah.
Okay.
Yeah. And they also, there's a lot of, talk about Suboxone. There's also, that's used to help addicts get over their addiction. But the thing is that that can also be used so that if they are going withdrawal, you can buy Suboxone on the street too. You can buy it on the street, so a person conceivably could buy some Suboxone, so if they were sick during the day, they could take some Suboxone, and that would get the sickness away. And then when the Suboxone is out of their system, then they could use an opiate again. So there's a lot of different ways that people can manipulate, basically they're medicating themselves. There's a lot of different ways they can manipulate this to work. But eventually it catches up with them. You can't do this for long. I've had people who talk about, they've got jobs, and I always casually throw that out there, is that you're functioning for now until the addiction gets too strong, and now it just becomes all consuming, and you can't make enough money to maintain your addiction, and you can't work anymore because of your addiction. It eventually does catch up with people. Yep.
Do you know if they have, in the CPR course, if they teach to have a barrier?
I don't know.
You don't know?
Yes.
Yeah, they do.
They do?
Yes, they do.
Oh, okay.
I wish my wife had known about that.
Yeah. Yeah.
She had a person just fell down in front of her office and at St. B's, and
Bless you.
then she just went out. She was dead. No heartbeat, no nothing. Unfortunately, my wife was a nurse and decided to do the mouth to mouth, and somebody else was helping her. Until they got the fentanyl,
Knock in.
whatever.
Knock in, yeah.
I can't remember.
Oh, that's okay.
And, and it's like she just got done testing. I mean, not that this hasn't happened, we've been married for a long time, and it's happened with needle sticks and stuff like that.
Yeah.
But unless you have that person give permission to do a blood test, you got 6 months of testing to do. Luckily, nothing happened.
Yeah. Well, and also, fortunately,
I just wish,
yeah. Well, fortunately, things like, there's a decreased risk of catching hepatitis C or of HIV through mouth to mouth. It's just something that we know that people are concerned with, and we're trying to figure out how to make sure people are doing rescue breathing and doing it safely. But if X amount of people are saying, I am not going to do mouth to mouth on that person because of my concerns, then we're just, again, it's called harm reduction. Say, okay, but would you do mouth to mouth if you had a barrier? Well, yes, I would. Then okay, we promote people using barriers. Because our idea is just to try to get us all motivated to try to save that person.
yeah, they did save her.
Yeah, yeah. Yeah, it's very, NARCAN is very effective. It's not a miracle drug. If a person's been gone too long, it can't bring someone back from the dead. You can only go without oxygen for so long. But it's very effective. And one of the things about the NARCAN now is like these are relatively new. They've been around a year and a half. There used to be older ones, but they were half the strength. They were 2 milligram. These are 4 milligram. So these are much stronger. The old ones, all these new ones, it's a vaporized spray. The spray is much finer and better now. The old ones, it used to be more of like a stream of liquid. So basically, you were shooting a stream of liquid into the back of someone's nose. So you'd get a lot of choking with people when you used to do that. These are much more effective. They get into the person's system faster. And because of the strength of them, it addresses the fentanyl that's out there. Because, like I said, that's really the driver right now because of all the fentanyl out there. Anybody have any other questions? Or? Sure. No, that's quite all right.
You said before if a child got into that package, it wouldn't do them any harm.
No.
Why is that? It just, if there's nothing attached to
Yeah, I can't speak for the medical reason why, but we just know that it's not harmful to anybody unless you have an opiate in your system. And that's it. Otherwise, it doesn't affect the body. Because we're one of the distributors for the state of Massachusetts, we have monthly conference calls with the state and with other distributors. So we're also constantly going over, any adverse effects. We always want to know, are there any adverse effects, so we can kind of get ahead of it if there have any. But we've been doing this for a few years now, and there hasn't been any adverse effects. There's not even any allergic reactions that we've heard of. So it's a safe drug.
And obviously, the more that, because they're doing multiple doses of that and whatnot, but obviously the more, if your respiratory system slows down enough and your heart's obviously slowing down, and then the NARCAN helps with the brain, so to change that, which brings your heart rate back up. But I imagine after so many times, your heart has to be affected, right? That many times going down and up and...
Well, opiate use does cause heart disease.
Okay.
So just the use itself does cause heart disease. So whether they're getting NARCAN or not, I would imagine, not being a doctor, I imagine if you're overdosing and brought back, it's got to be just one more catastrophic event for the heart.
Okay.
Be constantly to be being, on the verge of stopping and then coming back, on the verge of stopping and coming back, on top of the opiate use. It definitely causes heart disease on top of everything else. Yep. Is there anything else?
I just had a question.
Sure.
Economically, there's so many people using, it seems these days, and young people using them.
Mm-hmm.
And where do they get the money to?
The
I mean, it's
state.
gotta be
They get it from the
expensive.
state.
Have it.
Well, all the panhandlers you see in the city of Worcester, a good amount of them, they're panhandling for money because they don't do a lot of eating. They're going to spend money on their drugs before they do that. And then unfortunately for a lot of the young women and the men, they get into the sex trades. Men don't talk about it as much as the women because there's more of a stigma involved. But the type of men who prey on these type of people, they know they're out there. They know where to go. And then the young women and men have to make a choice of what do they want to do. Do they want to get sick, or do they want to commit this act that's going to allow them to buy their drugs. But once they get addicted and they're starting to go through withdrawal, it's very difficult. It's a very difficult decision for them to make, and a lot of times they have to succumb to that. And the other thing is the drug dealers are very aware of that too. So it's very easy for drug dealers to get young men and women into the sex trades. And once that happens, it really is nightmarish. You know, this is not stories of pretty women and the stuff that we put on in movies and on TV to glorify these things. This is we don't even talk about prostitution or pimps anymore. It's sex trafficking and sex traffickers. We don't want to give them the honor of calling them something like a pimp, because we always think of things that are on TV that are so funny. This is not funny. We hear nightmarish stories of what happens, and it happens every single day. So that's where a lot of the money, unfortunately, is happening. And like I said, the drug dealers are aware of this, and they have no qualms with using these people to protect themselves. A lot of times they're the ones who are carrying the drugs and not the drug dealers.
And I guess this is where you hear about these drugs being sold cheap.
Mhm.
And they're probably worse than if you get the good stuff. That's a big problem there, I imagine.
Well, what's that again?
Being able to buy it cheaper
Yeah.
than, because it's being made differently or something, but.
Yeah, but again, yeah, it's definitely cheaper than other drugs that are out there. But then, depending on your usage, it becomes expensive when you have to buy more and more and more. And at that stage again, you got to remember you're not working, and so you don't really have money sources. And obviously, and there's also there's theft and everything else that goes involved with people who are doing that. That's you have petty theft, shoplifting, break-ins, and stuff like that. That's also happening. But unfortunately, with what we do see a lot of the sex trafficking that goes on, because we do have people in our organization who work specifically with the young women who are being exploited, and work with other groups that are trying to help the young women get away from it. Because that's part of the idea behind our outreach, or street outreach, because a lot of the young women who have been exploited like this, the people who are watching them don't let them come see us. They don't want them talking to us, because we'll be talking to them about changing their lives, and the people who are controlling them don't want us around. So that's why it's important for us to be able to do street outreach, to be able to talk to them, and to be involved in these other organizations that specifically go out looking for them to talk to them.
But also, because it's in my family,
Yep.
some of these people are on state aid.
Mhm.
And they get Mass Health,
Yep.
they have no co-pays. So, for instance, the person that I'm referring to will get the Suboxone and go sell it, have heroin. The state of Massachusetts is giving this person money to go
To get
kill herself
Suboxone.
on drugs. So, there's gotta be some kind of a, okay, you do it once or twice and you're not gonna get this aid anymore, or there's gotta be something to stop them from giving them money to go and kill themselves.
Well, yes, I agree.
Everybody else's.
Yeah, I'm not, it's more of like a system problem that I'm not, I myself aren't ready to be able to try to solve. But probably the better idea is some of this is water under the bridge. It's happening, it's not going to stop. But the idea is to have less and less people get caught up in it. Because I think what happened is it was something that wasn't really being observed, and then it just, like I said, the horse was out of the barn before any of us knew what was going on. But now, like I said, I deal with so many communities that have their opioid task forces and action committees, and it's throughout the Commonwealth now that people are reacting to it. So I think, I don't think the crisis is over right now, because people are just starting to catch up with it. But I could see it shifting the other way if we all, stick to it. And there's, like I said, there's lots of organizations out there like ours who are working on this, and more people are becoming aware of it. And the kids are being spoken to much more about it. There's more, there's more regulations involved with prescribing narcotics now. So I think a lot of the different things that helped get the momentum of the crisis moving starting to get eliminated. So now it'll slow itself down, but now we just have to figure out how to care for all these people. And look for the loopholes in the system,
Right,
you know,
right.
but with all the systems, you know, there's always loopholes in all the systems. You
But I
know,
think that's a loophole that really initiates their ability to have money.
it could, but there's also people who are legitimately, I do know that there's people who are legitimately using the assistance to help themselves.
Oh, I don't, I'm
Yeah.
not saying that.
Oh, no, I
I
understand.
know it works and it's needed by many people,
Mm-hmm.
but I'm talking about the drug users who continually do this,
Yeah,
you know, to kill themselves, basically.
Mm-hmm. yeah.
Or to wreck their families or to lose their children or whatever.
Yeah. No.
It's sad.
It is. It's very. Yeah, it is. It's a very sad to see the situations. Like I said, I talked to tons of people. A lot of the people I talked to, you know, had perfectly, you know, quote unquote normal lives like the rest of us, and then it got out of control fast, and then you lose everything.
Yeah.
You know, and especially, like I said, then once you start burning all the bridges of the people that you knew and loved, and they knew and loved you, now it's just even harder to climb out of.
Well, Carolyn, what you just mentioned about being given Suboxone and then they go and sell it, especially if they're in a treatment program.
Sell it for
Why-
heroin.
Why can't we stop that? Why can't they take it in front of the person? Why do you?
Whoever's prescribing it, and I know at least with narcotics, I'm not sure how it works with Suboxone, the doctors that are prescribing it are supposed to be testing your urine, whether it be monthly or every
So
3
they
months,
take it.
to prove that you're testing positive for that medication, or you'll be cut off. And that's how they're trying to get the narcotics cut back, is that if they
Okay.
go in for the prescription, they're gonna be randomly drug tested on the spot to prove that they're not going out there and selling it on the street.
Okay.
So
But do
depending
you
on the
know how they
doctor-
can skew those drug tests?
They can't. Well, because if you're doing it right in the doctor's office, you're doing it right in front of a staff member. And you can't, it's random. It's not like they're going, come in for a drug test.
Yeah.
Yeah.
That's how it's supposed to work. I'm not saying it does.
That's the way it's supposed to work. It's not the way it works.
I think a good thing to put out on the TV is you're a state-supported organization
Yes. Mhm.
and free and open to the public at any time. So the hours, maybe just put that
Oh,
out.
sure,
Your
sure.
availability,
Sure, thank you.
Things
Yeah,
like
we're
that.
open Monday through Saturday. Monday through Thursday, we're open from 8 to 5:30. We do testing up until 4 o'clock in the afternoon, then we stop testing. On Fridays, we're open from 8 to 5, but again, we do testing right up to 4 o'clock. And then on Saturdays, we're open from 12 to 5, and again, we stop testing at 5 o'clock. And anybody can come in. You don't have to be an active user. Anybody can come in to access our services. We have people who come in and get syringes who are diabetics, whose insurance, for whatever reason, doesn't cover the needles. So they'll come in and do that.
Yeah.
Yeah, for people who can't afford to buy needles, we don't discriminate against who does and doesn't get needles. So we can do that. We also, and I didn't talk about, we're AIDS Project Worcester. The other thing is that we still are addressing HIV in our state and in our community. It's still prevalent. It's kind of gone off the radar, but it still exists out there. And we're also a very good resource for anybody who you may know who's been exposed to HIV or who may find out that they're HIV positive. We have caseworkers and peer support people. And basically what they do is they help people navigate all the bureaucracy of getting doctor's appointments and all the assistance that the state and federal government provides for people who've been infected with HIV. Yes?
Is there a program out there that offers assistance with medication? Because I know some of that medication, even Mass Health, doesn't cover a lot of the time, the majority of it.
Yeah, not dealing directly on that side of our business. I want to be careful, but it's my understanding that just about there are programs out there that do provide funding for HIV drugs if people can't afford them, and it's pretty extensive. It's like for an agency like ours, if someone to come down, we would be able to hook people up with agencies in places that they would be able to get their drugs. The cost of drugs normally isn't an issue with HIV anymore. Unfortunately with HIV, and there's been a lot of, since we're talking about it, bring this up. And there's been a lot of advances with HIV. You know, there's drugs such as PrEP, if anybody's ever heard of PrEP, or PEP. PrEP is a pre-prophylactic drug that if you live a high-risk lifestyle that exposes you to HIV, you can take PrEP on a daily basis. And PrEP has a 98% effective rate of keeping you, so even if you're sleeping with people who are HIV positive, it has a 98% effective rate of keeping you from getting HIV, which is just as high as a condom. Then there's a drug called PEP, and PEP is a post-prophylactic, and that would be a case as if you were sleeping with somebody and the next day they say, oh, by the way, I'm HIV positive. Well, if you take PEP within 72 hours of the exposure, that also has a very high, I don't know it off the top of my head, so I don't want to quote it, it has a very high percentage rate of stopping the HIV virus from spreading into your system. And a lot of people aren't aware of that, and we have to bring that up with people all the time, because when we're doing testing for different STIs, we go over people's risk assessment, and we may bring up to them, have you ever thought about taking PrEP? And they'd be like, what's PrEP? It's like, well, this is what it is, and from looking at the questions you just answered, maybe you should be considering this.
How do they get it? Do they have to go through their doctor? Or?
Yeah, they would have to go through their doctor. I believe PrEP, there's a program at UMass Memorial that people can access that helps facilitate it.
Has it too?
Who does?
The infectious disease that St. Pete's does as well.
Yeah, probably. In PEP, in my understanding of PEP, and I think I'm correct about this, and with PEP, I think any one of us, if we were to go down to the emergency room tomorrow and say, you know, by the way, I slept with somebody last night and they just told me, I think that they're required to give me PEP right away. I think we discussed the payment of it later, but you're supposed to get PEP right away.
Does that work with needle sticks as
That's
well,
my
or just
question.
sexual exposure?
Oh, no, it's just any exposure.
Any
Yeah, any exposure.
Not just
Yeah, whether it needles or sexual
That's
exposure.
good to know.
It's not. I think we should spread the word about that.
Yeah, really?
Yeah.
You should, in the nursing community.
I know.
Yeah.
And also, since we're talking about it, and it's also the thing with HIV and AIDS now too, is just like, and it's not the, hate to say, but it's not the death sentence it was 30 years ago. You know, I know people, and people who I work with who are open about this, they've had HIV for over 20 years, and they're med compliant, and they're living very good functioning lives. They have relationships with people. I mean, HIV is to the point now where depending on your meds, when they talk about the viral load that's in your system, it can get to a point where it's so low, you may still be HIV positive, but your viral load is so low now that you can't transmit it to somebody else. So there's been a lot of advances in it, and also advances in the meds where you're not taking the quantity of meds. You know, there was a time, we have a display at my job where it's a big poster board that's just covered with prescription bottles. And that's an indication of the amount of meds some people were taking when HIV and AIDS first came out, and and people were basically trapped by their medicines, because some medicines you had to take every 2 hours, some you had to take with milk, some you took with water, some you took with food, some you took with no food. You had to set your alarm clocks because you have to take it every 2 hours, so you got to get up, you know, you got to get up at 2 o'clock, you got to wake up at 4 o'clock, and some people sadly just decided, I would rather live my life and die than have to do this every single day. So there's been advances now where the amount of drugs people are taking now is something that's manageable, and it doesn't wreck their lives. Because I've had people, unfortunately, I've had to talk to people who I've tested who are HIV positive, and I had to explain that to them, that no, this is, as much as yes, your life is going to change because you have to take meds, but it's going to be like taking blood pressure medicine. You take it every day. That's it. It's not going to, you know, it's not going to be any more inconvenient than that. I mean, there's a little bit more seriousness to the illness, and you need to stay compliant. You need to be careful about other things, and obviously you need to be very open about it with any partners you may have, but it's totally different than what it was 25 or 30 years ago. And that's one of the things our agency can help, again, with people who are dealing with it, that we can help explain to people that it's not what it was, and this is what we can do to help you get through this, you know, the original hump of getting through all the bureaucracy and making sure you're getting the treatment that you need. My agency also runs programs for LGBTQ youth. It's called Swaggling. So if you know any families whose children may be struggling with their sexual orientation because of problems they may be having in school or society or in general, it's a group that also meets at our organization. I forgot how young they can start, but I think they age out at 22 or 23, but it's meant for teens and young adults who can get together and talk about the issues that they're going through so they don't have to suffer alone. We also have a transgender group that meets because you do have this population in our society that's stigmatized, and they meet also on a weekly basis, same type of situation. It's all people who are dealing with the same situations. They get to talk about it, and the people who facilitate these groups make sure they have the most up-to-date data on resources people can get into to help them during their transition. We also, and we have links to lots of other organizations too. You know, we know of residential treatment places that deal specifically with pregnant women or women with children who are dealing with abuse and they haven't lost their children, or the children are in DCF, and but they're working on reconciliation, so they go to specific residential homes that will help facilitate. They work directly with DCF to help DCF and the families, you know, get back together. Or again, if the mother hasn't lost custody of her children but she's dealing with the addiction, she can go to these residential homes. A lot of people don't realize these places exist out there. So there's a lot of different avenues that we can help people. If we don't do it ourselves, we normally will know somewhere to go to address a lot of these different issues. Have any other questions? I want to thank you all for coming out and listening to this. And if there's anything I can do, thank you. And I almost forgot to say, and I do have NARCAN. If people would like NARCAN, I can give them NARCAN. There is a form I need to fill out. It'll maybe take a few minutes, and I have to fill it out for every single person. I'll just get some chairs over there, and I can start filling out the forms. I can give people the NARCAN, and if you have any other questions, you can ask me then. So again, thank you for inviting me out.
Thank you very much.